Okay. I think you can see my this thing. Right. So hi everyone. So myself, Dr. Srinivas Midivelly. I cleared my MRCPCH like recently. So I thought like I'll share the view, what all the things we can do, how much time it needed to prepare for the exam. So I'll give a brief things, okay? And I do started a few things like WhatsApp groups where you can prepare together along with your friends. So please do join that so that you'll understand it's more of practice rather than sitting in your libraries and reading. If you keep practicing, it will be an easy exam. If you don't practice, I think it will take time for you to present in your exam. So what is the main aim? Why do they conduct this exam? So it's like the way they practice in UK, they want to implement in the divided into stations. In normal, whatever the Indian exam centers or in the other centers, we do have a practical examination after our theory. So it's the same way, clinical is in the same way, but they divide into 10 stations like development, it's completely developmental assessment of the child. History, it's taking what is the art of the, you're going to take history. And clinical stations, it divide into 4 so that each station is a examination of the particular system. Like one station can be CNS, one station can be respiratory, one station can be cardiac, one case can be a musculoskeletal or general. So they're going to assess you individually. So each station is every station they're going to assess you clinically, complete clinically. That is the reason they divide into. And coming to the communications, they implemented communication so that you have to give communication to the parent, you have to give breaking bad news, you have to give information to your colleague, how to deal with your difficult colleagues. So everything, whatever they need, actually the practice you need in UK, they divide into different stations. And video, so they cannot put acute critical ill children in the exam. So that is the reason the concept of video has come. So they can, most of the videos can be like rash, like they'll be having a Steven Johnson syndrome where the child cannot be kept in an exam and asked for the examination. That is the reason they divide into like bronchial asthma, who is having a severe exacerbation, or a bronchiolitis patient, or a foreign body. So different, whatever the seizures, convulsion child. So whenever you see such critically ill, you cannot take them to the exam. So they divide it into different stations, and video stations are meant for this. So have a broader view, don't go with a smaller view. So 10 stations, they're going to assess complete clinical skills of you, coming from the history, development of the developmental history and developmental assessment, and clinical systems and management plan, communication with them, and acute care of the child. So this is what the 10 stations of your MRCPCH is meant for. So your preparation should be like that. Whenever you're reading a guideline, you're preparing, the guideline should be like, you have to read the history and think that this history is also can be asked in your video station even. So make sure that while you are preparing the same cystic fibrosis, because the child can be having a chronic history, so they might be asking a history for a cystic fibrosis and the management plan. Now the same child may have a acute pneumonia where the child can present with a respiratory failure, that can be present in your exam. So having a differential diagnosis. So whenever you read a guideline, put in your mind, you have to cover all the stations together. Okay. So going further, so the main aim is the same thing I said, like they wanted a skilled trainee coming into the UK and practicing. So that is the entry point. Wherever you entry, they want someone who is knowing everything after theory. You can see my screen, right? Someone please text me if you can see my screen. Because okay. So what as I said, what they're expecting, they expect all these components. Whenever you're going for the exam, they expect all these communication, establishing a rapport, history taking, management planning, physical examination of the systems, clinical reasoning, child development, recognition of the acute ills, and professional behavior and ethical. So all these components will be your scoring. So they score according to this. So whenever you're going for a station, they score according to the, I'll show you the exactly how they're going to score you in individual stations. Okay. So marks, coming to the marks. So we always should know how much should be our preparation time. So where we have to put a lot of time. So we have 10 stations, as I keep saying. One is the developmental station, which is the longest station. I can say it is 22 minutes and it carries 12 marks. And the second, the history station, it is 10 marks and it also carries 22 minutes. And 4 clinical stations. Here you can get a case of CNS, you can get CVS, you can get an endocrine or short stretcher, you can get respiratory, you can get cardiac, you can get musculoskeletal, and you can get any general examination like a Down syndrome, anything. So the possibility of getting any system can be there in clinical. So and I always feel that we can score good in clinical, because here you can show your skill. Remaining all will be like theoretical, more or less. But in clinical station, once you pick the clinical science, once you get the diagnosis, you can generate the discussion and you'll get a full score. Most of the time, clinicals, you'll get full score. There is nothing like even if you get differential diagnosis and you tell the approach and you tell the management plan, you will get a full score. So next is your communication, which is the easiest thing for most of the clinical exams. But it needs a lot of practice, because in general, we don't do these things. So if you keep practicing every day, you have to do, there are like 60 to 80 scenarios where you have to practice. So if you keep doing every day, whenever you go for a walking, whenever you're going for a car, whenever you're driving, keep doing this communication test with your colleague or who are preparing. So that will give you a lot of confidence. And coming to the last 2 video stations, these carry 6 marks each. You have to go enter and you have to just see the video and pick it. Okay. So moving to the, so 1 developmental, 1 history, 4 clinical, 2 communication, and 2 video stations. As I said, the same thing. So developmental 22 minutes, 12 marks. So highest is developmental, history 10 marks. All clinical stations each carries 88 marks, so 32 marks. Communication each carries 88 marks, so it is 16, and video station carries 12 marks, each carries 6. So total is 82 marks. So how much you're going to get in 82 marks to pass? So the pass scoring is 62. Okay. So this is the exam circuit, how you enter to the exam, how you perform. So once you enter into the exam center, there will be circuit like this. So it will start like station 1. It can be 4 clinical together. It will be clubbed together. Once, if your first station is clinical, you will have continuously 4 stations clinical. Then you may get a development and then history and again communication clubbed together, 2 communication and videos clubbed together. So you will follow in this way and you will finish your exam. It will carry around 2.5 hours. So how they're going to score you? As I keep saying, na, so everything in MRCPCH is a scoring system. So every dot is important. 82 is 82 dots. So they will score according to your performance in the individual score. So and each station will be scored individually and sent to the board, and the board will calculate the total marks and give you a result. So it's not like everything will be calculated in the center and you will club the score and they will send to the board. No, it is like each mark sheet will be scored by the examiner, will be sent to the board, and they will score all together and give you the what is your scoring. So it should be 62 to clear the exam. So how they're going to score? So A1 is the information, how is getting the information, how is giving the information, and how he is going to do a physical examination, how good he is, how careful he is doing while examining the child, and identification of the clinical signs, how he is going to identify the clinical signs. Whenever you go to the clinical stations, the most important thing is they already know about what are the signs present in the child. So you have to pick that signs, so coming from the general examination, coming from the systemic examination. If they, I'll say once we go to the clinical station, what all the things you have to ask, and clinical reasonings and communication skills. So your all scoring system will be in this A, B, C, D, E. So they will check in this format whether you're doing good in that particular score. They will give you as met, standard, borderline, and below. If you get borderline in few, it's okay. If you get below standard, then the scoring will be going less. Okay. So they're going to do 41 domains. As I said, like they'll check 41 domains, and they into two. If you meet two, meet standard, then you will get 41 into 2, that is 82. Just imagine if the scoring system is 62. So you can, there is the spare of 20 marks. If you get like 10 stations, 1 or 2 marks less, still you can pass. Okay. So put in this mind, if you get a good score in other station, one station, losing one station, even you can pass the exam. So concentrate on where you are difficult, what are the difficulties, where your preparation is going. So what is as I keep saying, this developmental station is, I think many people think it is very, very difficult. Even I am, when I started preparing, I felt like developmental station is very difficult. But it is the easiest station if you know the format, and if you know how to approach it in a schematic way, you will get the score. And it doesn't require much time even, because you need to by heart milestones in and out, and you should know about approach, how to take the history of the development, the format, and you should know how to present the developmental positive things, and you will give the differential and management plans. So here it appears to be difficult because we regularly don't practice the developmental history. That is the reason you feel it is difficult. But believe me, it is the only station where you feel and you get a lot of score. So so it all requires preparation and practice. So how they're going to how they're going to assess your developmental skill? So once you go inside the exam hall, if the station is development, you have a role player, where the role player will sit there and you have to ask the history. Then after history, you have to go back and assess the child. So most of the exam centers, there won't be any real child. You have to just ask the questions according to the appropriate for the age mentioned in the information sheet. Once you finish that, then the examiner will give the clues whichever required for your assessment, and they will tell whatever. If you ask like gross motor, is the child can walk, if the child can run, if the child can sit, so they will say yes or no. Based on that, you will get the information and you will get the age of the child. Okay, so it is with the role player and the examiner. So total 3 people will be sitting in the room. The first role player will give the information of the history of the development. You will ask the history of the development. Then the role player will leave the hall. Then you will be with the examiner. You keep asking the examiner how to perform the developmental skills, or you can do it whether sometimes the examiner can play as a child. He can act like a child, and you can play with the child, and you can get the developmental assessment of that particular child or the scenario they given. Okay, and as I said, like the station is based on centrally written and bench marked scenario. So you'll get an information sheet from the MRCPCH side. So they will stick on in front of your developmental station room. So what they're going to assess, as I keep saying, we have only 4 domains: gross motor, fine motor, speech, language, social, and communication. So gross motor is more about posture and movement. Fine motor is vision and manipulation. Speech and language is hearing and speech, and social and communication. So these are the 4 domains they may ask you. They may ask you like, please do assess gross motor of this 3-year child. Please do assess of fine motor, or most of the time speech and social will be coming together. So they may ask you, please do assess for Rian, speech and social communication. So this will be the common command. I'll show the examples what exam center. These are the examples what you will. So what happens in a developmental station, once you enter into the developmental station, so you will have a particular candidate information sheet, that is CIS. So this is the one which is pasted in front of the station room. So for example, Joe is a 4 years old. He was born at 25 weeks gestation and has cerebral palsy. Please take relevant developmental history. So, and read what is the task. So during discussion with the examiner, your approach to the clinical examination of the jaw fine motor skill will be assessed. So in developmental station, whenever whatever assessment they asked, you should not ask the same motor skills in your history, because if you ask, the mother will not have the role player will not have the information. And if you ask the history, you cannot do the assessment in your assessment phase. So that is the reason, whatever the task they gave, you should not ask that particular motor skills in your history. Put this in mind. This is the most important thing. If you are given like gross motor assessment, don't ask in history about the gross motor. You can ask other milestones, but not gross motor. Okay. And this is the other example. Paul is 3 years old. His parents are concerned about his speech. So here, during discussion here, whenever they mentioned it as speech and social component, don't ask the history related to speech and social. It's a logical thinking. It doesn't require anything. If you ask the history, there itself you will understand the age. There itself the social and speech developmental assessment will be done. That is the reason you should not ask, and you should assess in your task. Okay, this is the station flow chart. This is from official RCPCH site. So what happens is, as I keep saying, first 3 minutes you are sitting in front of the cabin, and this candidate information sheet will be displayed. There can be a video, audio, photo related to. Sometimes a syndromic child, they will place a photo. So you have to know about the syndromic child. The photo will be attached to the candidate information sheet, and you have to know, because you cannot ask the dysmorphism features to the mother. So that is the reason they may attach the photo to the before entering to your hall. So what will you do next? Once you enter, the bell starts. You introduce yourself to the examiner, and you will just greet. And you, once you enter into the station, you start asking and talking to the role player. You will take the detailed history. That will be around 6 minutes, and the helper, whoever there to warn you that the 3 minutes left, they will tell that 3 minutes left. So it will be total 9 minutes. And then whatever the information you got, you will just summarize and give information to the examiner. Once the 9 minutes is done, the role player will leave the room, and you will present the key points to the examiner. Now you are with the examiner. Here, what happens? What can be the chances? Whenever, suppose they ask you to do gross motor, the examiner can give you oral answers, like vocal answers, whenever you ask something, or the examiner can act like a child. Suppose is the Arif can walk, so the examiner will just stand up and keep walking. So make sure that how the examiner is acting. If he wants to act, try to be like you are with a child, and try to nag with like you are with a child, and treat him as a child. If the examiner is giving only information whenever you ask, just think that he is not willing to mimic or act like a child. Okay, based on this, you just assess, and you will end up with the information, whatever you give, you clubbed it together and give a differential diagnosis along with your primary cause for the developmental delay. And there they will ask you what are the probable differential diagnosis, what are the complications, what are the investigations required, how do you going to manage. At the end of 22 minutes, the helper will ring the bell, and you leave the hall. So as I keep saying, whatever the scoring system is in the same way. So information, how you got the information, is it the complete history, how he is going to assess and play with the child when doing assessment. Is there any clinical clues, like any interpretation, like how the child is acting, and your management and communication, how you're communicating with the role player, how is you're doing playing with the child. So most of the time there are no children in the station, so don't worry for that. But if the examiner acts like a child, try to be like you are playing with a kid. Okay, so I'm going to unmute yourself if you have any doubts till now, so that we can, you people can ask me here itself. So each station I'm going to unmute. What are the doubts you have? You can. Give me a second to unmute. Yeah. You can unmute yourself. Whoever have any doubts, particular regarding the developmental stations, you can just unmute yourself and ask me.
Are these all available in the website itself?
What all? I didn't get your question, doctor.
The screenshots, the ones that you've put.
Yeah, these are there.
Available. Yeah.
It's
given in the law.
available. It's available in your official RCPCH site.
Oh, okay.
There is, doctor, there is one file for this. I will upload in the group. Okay.
Yes, please. Thank you. Thank you.
I do.
Yeah,
that.
I will upload it. Yes.
Any other doubts do you have for a developmental station, or can we proceed for the history station?
Proceed, doctor. Proceed.
Thank you. So next comes the history station. Again, taking history is an art. As I keep saying, it appears to be tough, but once you keep preparing, if you are good enough in your guidelines, if you read your guidelines well and good, and if you know how the format of taking history, then it will be easy again. So they're not going to put difficult scenarios for history, because most of the recent recalls, even if you see, those things are very easy. They're not tough. Only thing is you should assess what they exactly need. So the most important thing is read the task, what they want, focused history of what. They'll give a scenario in front of your room. Again, once you enter into the room, before entering, you write the name of the child or adolescent, write the age of the particular child, and what is the chief complaint or something they'll give, write out that on the paper. And before entering, once you enter, what I say, like before entering, you make your own format in your mind, what all you're going to ask, and what is your differential diagnosis for this little information what they give. That will help you a lot before going into the particular history station. So they will mention it's the next station will be history station. So once you prepare your mentally, because it is 22 minutes, you have to be the examiner, role player. So be prepared and make your own differential diagnosis, because most of the time the examiner expect you to give a differential diagnosis for the information you get and how much relevant good information you gathered, and you ask the questions to get the differential diagnosis. That's where you get a good scoring in history. The same thing, everything is written from the RCPCH board. They'll just stick on the station in front of the room. Okay. So the same thing, I'm not going to discuss. The candidate will be required to examine the patient. Relevant will not be required to examine the patient. Here it's only history. So you need not to touch anyone. You just ask the information from the role player, and then there can be a growth charts. So you should use the growth chart, but most of the time you should be aware of the UK growth charts, not the Indian or wherever you're practicing. So go through the UK growth charts and assess the height, weight, how you're going to assess it. So what is the information sheet available in front of the exam? This is the only little information you will get. Marwan is 15 months old, has not put on weight in the last few months. This is a little information. So what are the things you have to note? Marwan is the name, 15 months old. What is the chief complaint? Is not gaining the weight. So please take the focus history and outline your management. So once you finish the history, they will ask you how. So they'll ask you what are the chief complaint. You go inside the room and you start talking to the mother of Marvin, and you'll get the information relevant, which is useful. So what are the differential diagnosis before going, not gaining the weight? It can be undernutrition. It can be because of a chronic disease. It can be like malabsorption. So you put celiac disease, neglect. So all this can be a differential. Before entering into the station, you should have 3-4 differential diagnosis, so that you will gather all the information which is required for your differential diagnosis. Okay, this is the most important thing. Whatever how much ever knowledge you have, but application in that particular time is more important. That comes with the practice. Okay. The second example, Fatima is a 4 years old, as presented with 3 days of vomiting, abdominal pain. So note the 4 years, Fatima, 3 days, a complaint of vomiting, abdominal pain. Have a differential diagnosis, just enter. Ask in the format, onset, duration, progression, what are the aggravating, relieving, and complicating. So what are the past history, family history? I'll tell how we have to take in detail history station. Okay. So this is the official, what is the scenario which will be there in your exam. This is the same sample piece which will be stick on in front of your history station. So they'll give the information. The role is you are a specific register. Setting is like your children's. I will unmute. Give me a minute. Okay. So I'm sorry. So your role is a specific register. The setting is in children's rapid referral clinic at a district general hospital. You're talking to Gregory, a 6-year-old boy, and his mother. So you have to note all this information. Take a focus history aiming to explain the problem indicated as you would be in the clinical study. So these 3 minutes you have to concentrate on this, whatever information is given. This is most important. The boy who was born prematurely has been seen regularly at your OP clinic because of respiratory has been noted by mother. So all this information you just write on your paper, whichever they give, rough paper, and enter into the station. So this is more because this says that you are ready to ask. You should not ask again name, what is the age of the child in the station. Okay. So again, what is the history station flowchart? It is a 3 minutes. They'll give you information, again, audio, video, photo, but most of the time they don't put all this. Sometimes if they want to have a syndromic, they will put a photo. If not, if it's a cardiac, they can put a audio, like a murmur or something. Otherwise, most of the time they don't give information. Whatever the information we saw in this previous slide, that will be the information given before you enter into the history station. And you have 30 minutes here. In development, you have a 9 minutes, but in history, you have 13 minutes with a role player. So you have to ask a detailed history coming from your present, past, family, social. So, and especially for adolescent, you have to ask the history of adolescent history, which is asking few other things other than with a normal child. So I'll tell in detail when we go to the history station again. And 9 minutes, once you will finish the 30 minutes, the role player will leave the hall and you have to discuss what is the differential diagnosis, what made you to think about that, and what is your management plan for that particular differential diagnosis, and everything. How is the prognosis, they can ask you. So at the end of 9 minutes, that is total 22 minutes, the helper who are there, they will say the station is over, you can leave. And it will be a continuous process. Once developmental, next history, and next you may get clinical or communication or a video. So you won't get any time. You just keep running. As I said, how they're going to check your standards. This is the same thing. So next, do you have any doubts here in history station?
Yes, I have one doubt.
Yeah,
Will we
doctor.
be provided examination findings in history station or?
No, not at all. They'll give a clinical clue, whichever like age or a particular complaint, that's it. You don't get anything relating to exam because it doesn't need it. Whatever the differential diagnosis you get through the history, that is enough. You don't require anything. Sometimes you may get information saying that see, history station is not, history station is not same like our other countries. Most of the time, the scenario itself says that diagnosis is present, like 4 years child, cystic fibrosis. So you need not find the cystic fibrosis there. You have to find the complications of the cystic. Is the child having a regular visit? How is the child nutrition is going? Is he taking the supplements? So that will be the significant. And the other example I can say is like diabetes mellitus. Its child is on insulin, type 1 diabetes. So here they mentioned the diabetes is the diagnosis. You need not again take the history in detail to find that the child is having diabetes. You only need to tell why the child is not having a good control or poor glycemic control. So what are the reasons? So most of the UK history stations, the scenario will be chronic diseases like IBD, inflammatory bowel disease. So what made them to have a flare? Celiac disease. What made them to have a flare? Diabetes, cystic fibrosis, asthma. So all these will be your history station, not like child, you have to diagnose some neurological condition based on the symptoms. So put this in mind. This is little tricky. Most of the time, the history station, they will ask you regarding the follow-ups. Like I can give an example, like a 14-year child had a arrhythmia who was visiting regularly to the hospital, but as of now, he is not attending regularly to the hospital. So take a detailed history. So here, what is the type of arrhythmia, you have to find it out, and why the child or adolescent is not visiting. That is the main reason. Based on that, you will get the diagnosis, and why, if he is not visiting, what is your next plan of management, how many doctors you're going to involve, what is the next method of approach. So this is your scenario. It's not like typical what you get in, like you have to diagnose is like suppose if you have to diagnose a pneumonia or asthma based on your history. It is not like similar to what we get in Indian scenario or other. It is completely, you will get a diagnosis of the disease, but you have to find what exactly problem the child is facing today when he came to your clinic or the district hospital setting. Okay, I guess your doubt is
Okay,
clear,
thank you.
doctor.
Yes,
Yeah.
thank you.
So moving to the next station, clinical. I think this is the, I feel clinical stations is the easiest, because you can show the examiner that this finding is present. If suppose if the child is a cerebral palsy, you can show that there is a exaggerated reflex, there are contractures, there are hypertony. So there can be a salivations because of quadriplegic CP, pseudobulbar palsy. So you can show them where you can generate information and you can discuss with the examiner. So only thing we feel difficulty is a murmur or cardiac. So you have to be prepared with the cardiac scenarios, especially if you're going in UK, because most of the UK cardiac scenarios cardiac cases will be post surgery. They don't put the children's before surgery. So there the exam cases will be most of the time scar approaches. That is the reason you have to prepare in such a way, scar approaches. But in other countries, most of the time the exam scenarios will be a congenital asunetic heart diseases like a VSD, ventricular septal defect or atrial septal defect, the PDAs. These can be your, because the child can be stable, or tetralogy of Fallot, or post surgery of tetralogy of Fallot. These can be your cases. So here they want to, the clinical stations, they don't see you, like you cannot assess everything in 6 months. So they see how you are behaving with the child. This is the only station where you are dealing with the children. No other station you are talking with the children. So 4 clinical stations you are handling. They see how easy you are with the child, how good you are talking and communicating. In case of MSK, the child may have pain. So how we are going to talk to the child before touching. So those are the things where you have to be very, very careful. That will give you a good score, other than just identifying these things and giving a differential diagnosis. Okay. So the main aim of this is how we are doing the technique of examination. So every station have a schematic way of approach. For a CNS, how you do. For a abdomen, how you do. Respiratory, how you do. MSK, how you do. So learning the schematic way of approach is more important for us. Okay, because here the time is very less. Imagine it is 6 + 3, 9 minutes. So 6 minutes you enter the examiner. Here what happens, before entering into the room, there won't be any information given to you. The candidate information sheet will be empty. They'll be saying that the next station will be a clinical station. That's it. Clinical station 1, 2, 3, 4. They won't say you whether it is a CNS, CVS, respiratory, cardiac. Some exam centers, they are mentioning it, but most of the centers, they are not mentioning because they can shuffle the cases. That is the reason they are not mentioning it. So once you enter, you greet the child, greet the parents, greet the examiner, and take the command or order from the examiner. They will say that he is Asif, 8 years old. Please do cardiovascular system examination along with a general physical examination relevant. So listen to the command and go ahead. It is not like just the remaining all station, you will have an information sheet. But here it's an oral command given by the examiner. If you are not listened it properly, ask again, because if you waste the time doing something else, I think you will lose the station. So don't be shy there. Be open. If you're not able to pick up what he said, ask him again before going to the child. Okay. And make ease to the child. Talk to the child, make a rapport, then start your examination. Okay. Every CNS, as I said, like every CNS, CVS, cardiac, there is a particular thematic way of approach for the RCPCH. So if you follow that, if you practice that, it's easy to get a good score in a clinical, because you don't have a large number of cases. Suppose I can give an example of cardiac, what do you call it? CNS cases. Most of the CNS cases will be cerebral palsy, hemiplegia, and your spinal muscular atrophy, your Duchenne muscular dystrophy. So these are the typical cases. Once you go there, you will find the things, but they will see how you are approaching the child and how you made the differential diagnosis. So whether there is a proximal myopathy, whether there is a distal myopathy, there is a pseudo hypertrophy of the cough, or is there any cranial nerve involvement? So you have to see everything. Okay, then you can get the differential diagnosis, and then you can plan the management, and then you can discuss how is the prognosis and all. Okay. So this is the things where they are going to ask you: the cardiovascular system, neurology, musculoskeletal and respiratory, abdomen, gastro, very less, because abdomen, they can ask you leukemia, they can ask me thalassemia, they can ask you hereditary spherocytosis or portal hypertension. Just imagine whoever is stable, not sick. That is the only dictum. Whenever you see an exam, whenever you're preparing exam, the most of the cases should be stable. Okay. Ophthalmology, they can ask you like optic nerve examination, they can ask you squint. Dermatology, skin, but very rarely they'll ask you ophthal and ophthal. Yes, eye examination was asked so many times. And hepatology, the same thing, liver. Hematology, leukemias, growth and nutrition. Nephrology, very rare again, nephrotic syndrome and other syndromes. They can ask you in general. So make your preparation. All has this systemic way of presentation or approach. So if you know those, it will be very easy. So what is the other information you get? As I said, this is the little information they are providing. Some exam centers. Anita is a 14 years, has a difficulty in walking. Please undertake a peripheral neurological. So read the task if they mention, or take the command from the examiner. Make sure that please undertake abdominal exam, please undertake a cardiovascular. And if you don't listen it properly, then you will waste another 1 to 2 minutes, and you have a precious 6 minutes where you cannot perform it. Okay. So there's the same thing I told. 3 minutes. For most of the Indian scenarios or Indian exam, you will just sit simply there. You just wait for your turn. That's it. You go sit in front of the room and wait for the 3 minutes. You don't do anything. You don't have a paper or anything. So your mind will be fresh before entering to the clinical station. Once you enter, the examiner will give you a command, and you have to perform in the 6 minutes. And in 3 minutes, you have to discuss and end it off. And the helper will say, it's the station is over, and you will move to the next clinical. Okay. The assessment will be same again. Here there won't be history. That is the reason A component is gone. So physical, how we are doing physical examination, identification, clinical reasoning, and management. We finished 3. Do you have any questions for history? Please free to ask me anything. I'm here to answer for in detail. If you have any Any questions related to your clinical stations, please do ask. If no, we'll move to the, because you should get a lot of doubts. Then only I feel like you are going through it correct. Because I used to get a lot of doubts whenever I prepare for how I had to do this, how I had to enter, what are the ways we had to present.
Siri,
Akshay, do you
please
have?
proceed. Yeah.
Yeah,
Hello.
Yeah. Okay.
yeah, Dr. Samson, please.
In the clinical cases, what are the different cases we have to prepare? So, one of the common cases in the UK scenario, if the exam occurs in India, what are the
Yeah.
common cases we face day to day? What are the
I'm
cases we
I'm
have to
going. Yeah,
prepare
I have
now?
a slide. Yeah, that's a good question, Doctor. I have a slide on what are the common exam cases at the end of this presentation. I'll show it. I have that slide, particularly what are the cases you have to prepare. Okay.
Okay,
Do you have
thanks.
any other questions, Aksa?
No, proceed.
Yeah.
Yeah. Siri,
Sir,
proceed.
if they ask for particular CVS or abdominal examination, do we have to do general examination first and then we shape to, or if they ask, then only we have to do general examination?
Okay. So see the command, if they ask you to do general relevant physical examination and cardiovascular examination, you club together. You don't divide it. See,
Yeah.
whenever
Same
you
thing.
whenever you start an examination, so what you'll do when the child you enter, you just see the face of the child, how the child posture, how the child eyes are there, nose, ears, mouth, neck. You come to the what do you call the hand, you see the dorsum and you see the palm, you see the pulse. So it should be clubbed together. You need not to divide it. It will be because see there is a way of putting I think every exam case appearing in your exam will be discussed before coming into the exam station. So there will be 5 to 6 examiners will see the positive findings and they will choose that particular child as exam case. So they don't put you like in a very vague symptom, a very vague signs child. You will see very prominent signs. If it is like general physical examination, they may having Kapha-Lett spots, they may have a port vein stain, they may have a contractures, they may have a Erb's palsy. So that will be prominent. So because in 6 minutes you cannot do both general physical examination and a cardiovascular system. So if they are saying you will get a positive findings at least 1-2 in general physical. Suppose cardiovascular system, what is general physical is more important is whether the child had any pallor,
Yeah.
clubbing. So these are the things which most important because your differential diagnosis changes with the general. That is the reason they add up. You're getting my point?
Yes, sir. But my question, if they're asking to do only CVS exam, should we skip general examination? What I want to ask
That
if
what
they
Devesh.
don't ask,
Yeah,
if
that's
they
what.
don't ask specifically for general examination, they specifically ask for only CVS. Should we skip or should we not?
That's what I'm saying
No.
now.
No.
I'll say.
Okay.
So cardiovascular system examination is not just CVS, right? So you have to go through. You have to go through the pulse. You have to go through the JVP. You have to go through the nails. You have to go through the conjunctiva. So all together comes under your cardiovascular system examination. So whenever they ask you cardiovascular system, it's not apart from general physical examination because you need differential diagnosis along with. Because if the child coming with a congenital heart disease like asenetic congenital heart disease, pallor is more important because the child may go into failure with a pallor. So that is the reason you have to present that and your management skill. Whenever you are doing the management, you say that I want to correct anemia because the child may go into failure before correcting surgery. Okay.
Yes, sir. Got it.
Right. So we'll go to the communications. So communication is an
what is this per-flight neurological examination, like motor and sensory?
Yes.
Yeah.
Motor. So whenever they ask you particular, because it is very particular, they may ask you the motor system examination. You do only motor. Don't do everything. Like I'll check I'll check what you call pain, temperature, I'll do vibration. Don't do that. So there will be limited task given to be like examination of the optic nerve, examination of this eye. So whenever they say eye, you have to examine 2, 3, 4, 6. If they say optic nerve, do only 2. Okay. So whenever whatever the command you are getting orally, please listen to that. And because most of the clinical findings will be there in that particular examination only. If you do other things, it doesn't require. If I can say that they may ask you to do only lower limb motor examination. Don't do upper limb. Once you don't get a differential diagnosis of lower limb motor, then you can ask the examiner there itself and say, I would like to see upper limb even, because you cannot, once you want to identify whether it's a spina bifida, or if you want to identify if there is a Duchenne muscular dystrophy or a SMA, to find that hypertonia is present generalized, you may require sometimes upper limb even. So whichever relevant you have to ask. If not, you don't require. You will get a differential diagnosis based on that particular task. Okay. Right. Good.
So if they ask, if they ask us to examine lower limbs, should we do all motor, sensory, cerebellar, will all that be included, or PGALs?
Doctor, the command will be very clear. It won't be like lower limb examination.
Okay.
They will say lower limb motor examination, or they will say lower limb musculoskeletal examination. There won't be a PGAL. PGALs is very rare. They will say lower limb motor musculoskeletal examination. That's it. Then you have to do PGAL there. And you have to do all other beacon scoring, everything, whether the child have any hypermobility or hyperextensibility. So you will get the differential. That is, as I said now, every system has a scheme, how you approach. If you approach in that particular way, I think you can easily crack the diagnosis. If you miss that, because every task is very limited. Just imagine, can we do everything in that particular 6 minutes? It's very difficult. That is the reason the task is very specific. Listen to the task, just perform that. If you're not getting the information, you may ask the examiner, I would like to do upper limb even to get my differential diagnosis. But be sure that why you are doing that. Okay?
Okay. Thank you.
So going for the other main domain, I always say that this is your scoring system. Communication, 16 out of 16 you have to get it. There is no other like excuse. If you don't get 16, you may get tough in clinical. Sometimes you may lose the complete clinical station and a video station. Remaining all, you can get a good, like as I said, like 75 to 80% of score. To add that, wherever you are getting deficit in a clinical and a video station, here in communication, you should get 100%. So practice, as this is only practice, and knowing what I keep saying, communication is an art where if you keep doing in your regular practice, you can score very good. If you just go and act there, I think you'll get 2 to 3 marks less. What is communication? It's not just giving an information. It is always giving a right information. I can give an example. Suppose there is a child with meningococcemia. So you should know everything about a meningococcemia to tell to the mother. You cannot say what is the drug you have to use. You have to tell how much the child should be separated from the how many days, how it's going to be progress. So you should have that relevant information regarding that particular scenario given in the exam. Then only you can give. Suppose at 4 hours old baby born, and while looking, it appears to be a Down syndrome. So you should know about everything, how you're going to diagnose Down syndrome, what are the features which made you to think Down syndrome, what you're going to do next for the child, how you're going to get the information, what are the problems the child is going to get the. So communication is not just talking, but talking with a honest, real, good information to the parent. You cannot give the false, like Down syndrome may come out. We say like it will come down. Down syndrome, it will be will improve over the age. If you cannot say that, so you have to tell in the logical way what happens for the future of the child, how the child's intellectuality. So everything you should know, how they're going to diagnose, what is the diagnosis modality. So these are the questions will present with the role player or the parent who are acting like a role player. They will ask you all the questions. So communication is easy when you have enough knowledge about like bronchial asthma, cystic, anything, diabetes, smoking, drug abuse. Well, there can be any scenario where you have to keep counseling the mother, or child requiring LP, lumbar puncture, child requiring a bone marrow. So there can be anything. So what are the scenarios which they cover is information giving. So this is like telling about the diagnosis that your child got pneumonia and we need to intubate. Your child diagnosis, breaking bad news is we just got your blood reports and that's showing leukemia, or we just got the reports of blood that is showing suspecting what do you call the ambiguous genitalia along with your CAH, congenital adrenal hyperplasia. So breaking bad news, your any syndrome approach, taking consent, as I said, like lumbar puncture, your bone marrow, taking consent for any surgery, all these can be consent communication. Critical incidents like giving a wrong drug to the patient, whenever like wrong dose. So the mother will be very angry. So how you deal with the wrong dose, wrong surgery done. So, or postponement of the surgery, not informing the parent. There can be anything which is making the mother angry. Ethics. So it is like refusing blood transfusion, asking for extra antibiotics, asking for IV cannulation for not some dehydration. So you have to maintain that ethics and give the information. Educational, talking to your junior, talking to your senior, or taking information from your senior, or giving information to your MBBS graduate regarding, there can be a lot of scenarios for education, like tell about quality control, tell about evidence-based medicine, tell about research. There are a lot of things how you are to. So tell about Stevens-Johnson syndrome. So any information which is given. So all the communication scenarios will be covered in this form. So whenever you get a task, mentally you prepare what you're going to do. You're going to give information. You're going to break the bad news. You're going to get consent is there. Take the consent. At last, you have to ask that. I think we discussed enough. So are you going to give the consent for the procedure? Don't forget to mention this, because here you have to take the consent. Okay, critical insight, ethic, and education. So as I keep saying, select the most appropriate information to communicate. Provide information that is correct. Never use the information which is what you know. Everything is guidelined. Everything, all the information should be appropriate and near to your guidelines. Okay. Explain issues in appropriate way without jargon. Never use any language. Like you cannot say ultrasound. You can say jelly scan. So there is a file even to find the avoiding medical jargons. Okay. And respond and adapt to the emotional contents of the station. If mother is keep crying, if the mother is like crying like anything, you just told that your premature baby had an intraventricular hemorrhage and it's grade 3 and requiring ventilation. And the child is, if the mother is crying there, you cannot go information. You stop there. I'm sorry, I know how difficult it is for you. Today, if you want, we can stop the meeting here. We can resume tomorrow. Or do you want some water? You just please them. That is the where they want to assess you, how you are behaving when the situation is odd. So adapting to the particular scenario is important. It comes with the practice. You cannot, I'm saying
Doctor, you can give tissue also. That's very nice gesture.
Yes. So you can give water, you can give tissue, you can wait till the mother responds to your. Don't just go and give. That will give you definitely a negative scoring for you.
Yeah.
Okay.
Rude behavior, yes.
Yes. So this is again the sample scenario. What comes? So just imagine. Most of the communication scenario, the information to the candidate will be so big. Sometimes it will be like one page, complete one page. So take the important points. So always read what is your role here. You are a specialist register. So once you are introducing, I am the specialist register working here, so and so. I believe I'm talking to mother of David Milligan. So if there is no name, you can ask them. Okay, Milligan is there. So you can, these are the things, information you have to take into your room where you are talking with the role player. In communication scenario, what will you will be facing the role player. The examiner will be sitting on the other side and just watching you. They will never interfere or talk to you at all. Whenever you are acting, whenever you are just talking to the role player, they'll score according to your way and how you are adapting, how you are giving the information, whether it is a real, true, correct information or not. Okay, so here the examiner won't touch or ask you anything. Okay, so the task is to explain your management strategy for David's asthma. So you will tell about you wish to start David on beclomethasone. So twice daily in the first instant, use a large volume spacer. His mother has asked you to discuss this in more detail. So you have to take information. There is other information which you have to note it. So cough, wheeze, everything. Is there infectivity is going or not? How, whether the child is fitting into mild, moderate, or you will get the information and you will pass. Once you enter into the station, the mother will be sitting, Milligan will be sitting and expecting you to ask the scenario. So what will happen to my child? How is he now? What you're going to do? How much time it will take? What are the investigation you're going to do? How it's going to relieve? What I have to do at home? Do you have any specific things you want to give us information? Everything is based on your guideline. If you read wrong asthma guideline, all the whatever the role player will asking will be present in your guideline, and you have to tell what is the last asthma clinic review, what are the investigation, then what is your PFT, pulmonary function test, what is your PFR. So all information you can ask and they will give you. So every scenario is based on your information sheet. Okay, any doubts in the communication? Any doubts here, or shall we move?
No, Dr. Move, please.
Right.
Doctor, infection is jargon. We cannot say your child has infection.
It's not, infection is not jargon. You can use it. It's a routine word. You can use it. You cannot say disease, but you can say infection.
And vaccination?
You can use, you can use what you call shots. You can use the word shots. What was your last shots? Other than vaccination, you can use shots. When was your child took the shots?
Okay, thank you.
There is a file, doctor, for every word, how to replace it with your normal language. Okay, going for the last station, video. So again, as I said, now everything why they choose divided into 10 stations is to assess you completely before you entering into the UK. Okay, so here they're going to assess you the acute, like whenever the child present in emergency room. So you have to pick the emergency things like how is the rate, how is the child heart rate, how is there any distress, subcostal retraction is present, nasal flaring is present, how is the child color, is there any cyanosis? So all the how the child is doing, is he on child or ventilator or child is throwing a seizure. So all this can be is the child. Now what they did is they divided video stations into clinical setting. Even recently what they are doing is, because if they are not getting enough number of videos or anything, they're using they're examining a child. Suppose they're examining a motor system examination of the child. They do tone examination, they do deep tendon reflexes, and they do how is the power. So they will do all these things and give you information. Somewhere the tone will be less, somewhere the tone will be high, somewhere the reflexes are less, somewhere the reflexes are high. So you have to assess that. You have to pick from the video and give a differential. This is the recently they started like doing this even, because they can't get everything acute condition. So they're including the examination video. Sometimes they examine most of the time CNS only, because you can see those exaggerations, contractures, you can deformities, you can appear much in video even. That is the reason CNS they're using. Okay. In cardiac, they can make you to listen the cardiac sound, murmurs and all, respiratory distress, abdominal grade. The child they'll show you how the child is walking, if there is an ataxia kit, if there is child having any limp, if the child is having any circumferential gait, hemiplegic gait. So based on that, you can give your differentials. So again, this is the shortest thing. You will spend more time with the examiner here. 3 minutes, there will be nothing in front of your video station. They will say that this is video station. Sometimes they may put this is 2 years, this is 6 months, this is 1 month child. That's it. They don't mention the name also. Okay. Once you enter, there will be a laptop or a desktop which plays a video. They'll give you 3 minutes. Most of the time, the video should be less than 1 minute. That is one of the rule, but sometimes it can be more than one minute. So you can play at least 2 to 3 times. Start from the first. What happens with the video stations is the previous candidate may leave the video at 25 or 30 seconds. And you start seeing just playing it, and you just see from 30 seconds. So make sure that you go from first and see it. Okay. That is a very commonly happens in your exam stress. So go back, start from first and see it once, see it twice. If you have time, see it thrice. Make your mind. The examiner will be sitting beside. There will be particular 5 to 6 questions. That's it. They don't ask you anything more than that. In 6 minutes, they will ask you 5 to 6 questions and they'll you, because this is the least scoring, 6 marks. So whether you pick the right clinical signs from the video, what is your differential diagnosis, what is the history you're going to ask, what is your management, that's it. You'll get a score. So this is the example I keep saying. 4 years old boy presented with a rash. So 8 years old presented with a wheeze. This is the only information you may get. Sometimes you won't get even, but you will get this information in front of the laptop or desktop. So here again, the assessment, you don't have any history, you don't have an examination. So both are gone. AB is gone. So CD, so most of the time, clinical identification of clinical signs, reasoning for that, and management planning. Okay, this is the sheet, exam sheet, which you will get for information. As I said now, so this is you are a pediatric ST4 trainee. You have been asked to see a 4-year-old boy who is present to the emergency room with a short history of difficulty in breathing. He has temperature of 40 degrees. So video has sound. So you have to, if they mention, you have to play the sound even. They'll give you earphones or earbuds. The video is 49 seconds. You can play 3 times this video. So this is the only questions they will ask you. What clinical signs have you observed? What additional information you would like to ask in the history? What additional clinical examination you want to get the differential? Once you this finish, you will get a differential diagnosis. How you're going to investigate, how you're going to manage. Okay. So do you have any doubts in the development? If you don't have doubts, we can move to the next station. Yeah, doctor. Yeah, tell me, doctor.
No, okay, very good.
Okay, we'll go for the next. Okay. So books, the biggest thing for this session is books. Where we have to read, what we have to read, right? So I want people to talk to me. So what are the books you are reading? Just unmute and tell. What are the because you have exam in another 3 months or 5 months, 6 months. What are the books here? Other than AXA, AXA knows a lot of things. Other than AXA, I want someone to participate. Then I will tell what are the books you have to read.
Illustrated Textbook for Pediatry by Tom Lesner.
What, doctor?
Illustrated Textbook of Pediatrics by Dr. Lesner.
Okay. And any other books?
Guideline, pediatric and NICU guidelines book.
Very good. Devesh, please participate so that I'll give you relevant information so that how much time you have to spend on your books.
Usually just clinical examination, what we usually read in India, and I have a mark I am planning to read, but I haven't started properly yet.
Okay. Okay, that's good. So see, I keep saying this, you don't require many books, that's for sure. It became a phobia to approach MRCPCH clinical exam, but it's not like that. If you have a good clinical background, if you're done from a good medical college where your post-graduation has a good exposure to, you don't need to read like a lot of books. You just need to know how we have to present and approach the case. That's it. This is where it differs from the Indian or other countries other than UK. So if you know how to approach, that is more than info, because the disease is the same. If we, as I keep saying, that CNS, whatever the cerebral palsy, that will be same. Whatever the stroke causes of child, that will be same. What is the causes of how the child of SMA present, that will be same. Duchenne muscular will be same. It won't be differing. Only thing how you're approaching is more important. That you have to learn. So it's not like how many books you read, but the best book I can say, which you have to read in and out, you have to read at least twice or thrice, is MRCPCH. Believe me, if you read MRCPCH, I'll show the next slide. These are the things. Okay, so the most I just mentioned individually development, you don't require anything. You should know the format, how you ask the history, how you're going to assess the child. You should know milestones from the age of 3 months to 6 years at least. Every milestone, gross motor, fine motor, development. You have to make your own format for this. And you can get the help from the course providers who are providing it. There are a lot of information in the internet, but you need to practice it, because 22 minutes you have to be with the role player exam. You have to at least practice 10 to 15 before you going to exam, so that you will get the confidence. You keep practicing, try to give mock exams before real exam, so that way you can correct yourself. History station, again format, you have a particular format, because if you don't ask particular, I'll give an example for adults, and if you don't ask about smoking, she will never give you information. So you should ask, do you have any habit of smoking? Do you have any issues at the home? So family history is the most important in history station. I'll tell in detail about how we have to go with the history station. Clinical, again, MRCPCH in and out. It has a lot of information for a clinical stations, how to up. And the way approaching, you have to have your own approach and differential diagnosis of each cases. You cannot go just blindly and say, this is my diagnosis in clinical stations. You have to give at least 1 or 2, 3 differential diagnoses near to your primary diagnosis. So communication, there is the Rebecca and practicing. So Rebecca and guidelines. There is leaflets, information leaflets available in your NHS site. For every disease, there is a NHS leaflet available where how to give information to the mother or a parent. So there is a channel in Telegram for leaflets availability where you can add once you join this my group. I'll just try to forward that information sheet so that you can join and read for a Down syndrome, how to counsel and everything. And you have to at least present 30 to 40 scenarios so that you will get easy. Acute, all acute emergency, read from the guidelines, as I said, like rash. Whenever whatever the acute emergencies which you see in routine life will be your video station. Okay, so that you have to put in your mind and keep seeing seizure. How is the seizure in the YouTube or anything? How is it is different from the pseudo seizures? So you have to see the video so that you can pick it. So MRCPCH is the same thing. So this is the MRCPCH clinical shortlist. It has everything. If you read MRCPCH in and out, lot of information is given. Here they mentioned about short cases, history taking, communications. So three things are done. Only video is not there. Okay, video we have to read from internet. So for communication, there is Rebecca. Okay, there is a Rebecca where you can read Rebecca, and these are most important. Without guidelines, you cannot pass this exam. Read guidelines. That is what I'm saying. If you're not getting the slot, if you're not getting time, read guide. I think all of you people might read for your AKP or FOP. So read the recent guidelines, whatever the available. So these are the neonatal guidelines. This is the pediatric guidelines. Read in and out of these guidelines. Make sure you have a good knowledge. If you have this knowledge, it will help you in a lot of things. I said that it will help you in video, it will help you in communication, it will help you in history taking. So these books are very important. And there are many books. I personally don't want to guide you to read a lot of books because I am the person who make my own notes and read it. So that way we will differ because you have to gather information and practice that. So there are other books, Short Cases of MRCPCH, and you people can follow this book, MRCPCH Clinical Exams from Anil Garg. It's good. It has a text language how to present to the examiner. So you go through this. It is I recommend this book because I went through this. It is very informative how to present the developmental history to the examiner, how to present the summary to the examiner. It has a good information. Okay, and for your clinical things, if you have read enough clinical skills how to approach that, that is more than enough. So time for preparation, that's the biggest question which I keep asking. How much time you need, Dr. Devesh?
No idea, sir. I have 3 months try to cover it.
That's
You guide
more
me.
than enough, Devesh. You can do magicals in the 3 months. I'm saying believe in yourself, practice more. Then it all depends on your basic knowledge, how much knowledge you had in the pediatrics, how you are good in clinical science. All this will add up to narrow down your preparation time. Frankly speaking, we are our group who are prepared along with me, we spent around 50 days. That was like we dedicated that 50 days for MRCPCH. We read in and out, morning, evening, night. We used to practice. So that is enough. But if you have a good clinical background knowledge, that's more than enough. 3 months are good time. So that's what I'm saying. We don't have a time. Sometimes it may take 6 months. Sometimes it may take 1 year for a lot of people. That's just because of your clinical. If you have a good clinical background and if you have a good clinical theory knowledge, I think it's you just need to practice. You need to give mock tests so that you will clear the exam. Okay.
Okay, sir. Thank you.
Then someone asked me the same thing, common cases. So developmental station, you will have only few stations like autism. I forgot to mention here. Cerebral palsy, global developmental, ADHD, Down syndrome, Rett's with autism. So these are the routinely asked in your developmental stations. Okay. For history, it can be everything. For a clinical station, CNS, motor examination, cerebral palsy, SMA, DMD, hemiplegia, cardiovascular, ascending heart disease, cyanotic heart disease with operative, rheumatic heart disease, post-surgical scar. So abdominal thalassemia, leukemia, portal hypertension, splenomegaly, inflammatory bowel disease, respiratory, chronic lung disease like BPD, bronchopulmonary dysplasia, and cystic fibrosis, MSK, PGALs. There can be joint examination of juvenile idiopathic arthritis, hemophilia, joint, rickets, short stature, tall stature, hypermobility like homocystinuria or Marfan's. So all can be your cases. But if you know the approach, how you approach, you will get the differential diagnosis. History, endless. They can ask you anything, but my favorite will be this. You have to be in and out. If you get any in and out of this, you will get good score. Asthma, cystic fibrosis, diabetes, because all are like chronic disease where they deal. Constipation, even diarrhea and constipation will be added to celiac disease, rash, headache, convulsions, and adolescent history. Can someone tell what are the additional things you will ask in adolescent history?
psychological history and social history, how she's behaving with the
Yeah,
peers.
we have a mnemonic for that. It's heads criteria. So
Mm.
never ever forget, if the exam case scenario is 13 years or 14 years or 15 years, concentrate more on this last heads criteria, heads history,
Yeah.
because most of the information you get from there. And lot of the exam scenarios will be around 13, 14, post-pivotal age group. So concentrate on adult history more. That includes heads home life. How is the life at home? Is there any abuse going on? How is things at home? Who is the breadwinner? Who is financial head of the family? Education of the self and family, like how much she's studying, what parents were doing, how good they are knowing about the system. Activities, is she playing any sports? Affection, is she having any mood swings? Drugs, alcohol, smoking, sex. You should ask this for a 14 years, because the child can have a pain abdomen, and you have to ask, when was the last you can ask how the child is any of your relationship are romantic. You can ask the question in a better way. Okay. And school performance, suicidal, social media. So all, I think without this, if you are coming out of the history session of adolescent child, I think they will fail you in history, because this is the most informed, because there will be a lot of information ready for you to give from the role player. So be prepared for these things. Okay. What is the most important thing? I think leaked. So most important thing in any clinical exam anywhere in the world is practice. So you have to practice. Without practice, you cannot clear the exam. I'm sure that you cannot clear the exam. This is the exam where you have to deal with the people. You have to communicate with the people. So make sure that you do always that. So every communication, you talk to your senior. If there is a child, try to examine the child abdomen, try to examine the motor system, try to examine the respiratory, cardiac. So you keep doing that unless if you don't practice, I think you will get that's a new format, because most of the examination what we give in an exam, it's completely different. Okay, so make sure that you practice more, have good groups so that you can prepare well. Next. So what are the small groups? So at least have 4 to 5 likely minded people where they are available 24/7 in the last month. While you're driving, if you want to do some scenario of communication, you just call him and do it and let him do. So you should be a role player for the alternative, so that you learn a lot of things when you're being a role player. Okay. So biggest challenge. What is the biggest challenge for MRCPCH clinical? Anyone?
Communication.
No. Biggest challenge is getting a slot. Because
that
I
is the
waited
most
for,
important. Yes.
we all waited for more than 2.5 years, 3 years. Someone is waited for 3 years because of COVID. So what we can do? What we can do? So because I think these are the most important things you have to deal, because you cannot spend longer time. You cannot spend 5 to 6 years to get a primary degree. So what you can do meanwhile, if you are planning for UK after clearing MRCPCH, you can do 2 things. One is give your, that is as a biggest challenge is getting an exam slot, getting an exam center. So what you can do is give your English test. If you are planning for a UK, because this will be valid for 2 years, and you will get a once you get clear your MRCPCH, they will ask you your English test. And the second is EPIC registration. EPIC is electronic portal for international credential. This is certificate verification. You call it as like ECFMG. You may call it as data flow in your So it's the same thing. You have to do EPIC registration and verify all your certificates. So these will take at least 3 to 4 months or 5 months, 6 months. So meanwhile, if you're waiting and if you want to go to UK, you can do these two things. Write your OET English test. If you're not getting slots recently, write your OET, EPIC, make your registration, and you may get a slot. Once you clear MRCPCH, you can get GMC and you can move to UK. Okay. So what else? Any other questions related to your exam preparation? Please unmute yourself and ask me.
First, thank you very much to give us this very good overview. I have questions regarding the video scenario. In the video, we'll watch the video. Then they have a question regarding what are the provisional diagnosis, and the examiner asks me the related question related to particular video. Is it?
Yes. So it is like,
is it a diagnosis or maybe different diagnosis? Sometimes it may be possible that are not possible to give the pinpoint diagnosis. If suppose it is
true, doctor. True, doctor. See, I'll give an example for that. The child is 45 days old child, is a hospital setting, is on nasal prawns, taking oxygen, and there is a subcostal retractions, and the child is having respiratory rate around 90. So you cannot say that the child is having, it is because of pneumonia, it is because of bronchiolitis, it is because of your pertussis. Okay, you don't know, so you can put your differential. The child is in, so they will ask you clinical findings. You have to tell the child is having nasal flaring, the child is having retraction, the child is having rate of above this much, the child is in gasping, or there is a change of color, and child is requiring 4 to 8 liters of oxygen. Everything they will show you, and the heart rate is going through the monitor, they will show you. So you will tell that the child is in distress. So what other history you will ask doctor? The examiner will ask. So I'd like to know the onset, duration, progression. If it is sudden, if it's a 1 year child having 1.5 year child having a sudden onset of distress, it can be because of foreign body. So that is the reason. Once you ask, I would like to know about onset, they'll give the information of onset, duration, progression, how is it doing? So relevant history. Then you will ask a relevant examination. May I know what is the examination find of auscultation? If they say that there is a wheeze throughout all the areas of auscultation, then you can think it can be because of a bronchiolitis or anything. If there is a decreased sounds on the one side, then you can think it can be a fusion or an obstruction. Then you will give a differential diagnosis, and you will give I would like to go with an X-ray. I'll see how the lungs functioning. I would like to go a bedside saturation test. I would like to do a complete blood picture to see whether there is a pneumonia or infection. And I would like to treat. So it's all like a crisp. Okay.
Exactly.
So it is not tough. It's only everything is needed is just how to approach it. It comes with a practice. That's it.
Excellent. Thank you.
Okay.
So you were saying you had prepared for 50 days, right? I mean, could you continue working during that time, or did you have to take that time?
Yes, doctor. I took leave for 2 days.
Okay.
I took leave for just 2 days, but still it helped me.
It's very much possible to do both, right, sir? I mean, both practice and.
That's what I'm saying. These 50 days, you should be like doing everything, because if you sit at home, I think you cannot do much things. If you go to hospital and if you be with children, you can do a examination of cardiac, you can do examination of CNS, you can do a musculoskeletal, you can do a developmental assessment of the child. Only things you cannot do is communications and video. Remaining all indirectly, you can do it. You can have an habit of taking history from the mother. If the case comes, be a resident, first year resident, go sit in front of the mother. Take information according to your MRCPCH. Or take a history from your nursing staff who are close to you. So I felt it is very comfortable going hospital and working, because I myself is a consultant practicing from almost 7-8 years as a consultant. I do have a residence. So I made my residents to help me out. I involved them in examination. So it's a tricky thing. MRCPCH clinical exam is not the one where you sit at home and read it. It's not. Lot of people are doing this. That is where I wanted to tell, go to the centers where you find the cases, be with the mothers, be with the nursing staff, be with your residents, or communicate. You talk to you give information to your resident. You breaking the bad news to the nursing staff who is layman, who doesn't know anything. So that's the way you practice. The only thing, video, in the evening hours, you can spend with the guidelines and MRCPCH. Remaining time, you can spend with your clinical cases. Okay?
Good evening. Good
Yeah,
evening.
doctor.
I wanted to ask if it makes any difference when you book, in which country you should book the exam. Like there are some myths that in UK the pass ratio is more and in other countries maybe not the same. I just heard it. Is there anything true about
Yeah,
it?
see, I don't think there will be much difference, because it's all like people say that, but there is no reality in that, because it's very comfortable if you give in your home country, because you know the language, you keep talking to the children, you just you feel comfortable, right? If you go to the other country, somewhere like if you go to the British, like UK, communication, the role player will be Britisher. There, where you may feel, whenever you're talking to the role player, you may feel difficult. Okay, so the slang difficulties, communication, you may get difficult. History may, again, the
In
role
the
player.
home country, isn't it like that, sir? I mean, won't we have British examiners?
Examiners will be Britishers, but the role player won't be the Britishers.
And patients won't, I mean,
No.
they're not trained.
It is completely the exam center based cases. So that's what I'm saying. If you're going in South India, the exam cases will be little different. If you're giving in the North India, the exam cases will be little different. And
I mean,
UAE,
like
they
this
have.
time, I've seen the centers being Kolkata and the rest other states also. So would
Delhi,
we
Mumbai.
be finding it difficult, to communicate with the patients? I mean, because it's
See,
obviously
that's
not.
what, yeah, I want to clarify it. You don't require to talk to any of the attenders of the real cases.
Okay.
Because
The role players also are, they speak in English, they communicate in English.
yes, everything will be English. So only place where you have to greet is your clinical stations. Once you enter, you have to say Namaste, whatever the language, if it is a Kannada, if it is a Marathi, if it is a, what do you call, Bengal, you learn few words like Namaste, whatever the greeting them, and just talk to and take how to take the permission. Can I examine? That 2-3 words you learn in that particular language, and you need that much only. You take the permission and you go to the examine. You should not talk to the attender at all. Only other station where MSK, you should ask, is it hurting you? Is it painful? Because there can be a juvenile idiopathic arthritis where you have to examine and ask the child or see the child. So you learn hardly 4 to 5 words of that particular language. That's it. Remaining all will be without not dealing with your real cases. So you need not know that language. See, MRCPCH is such an exam. They are conducting in such a standard. There won't be any bias. That's for sure. Wherever they're conducting the exam throughout the world, they're trying to decrease the bias. That was the main criteria. That is the reason they allowed the exams in India. Yeah, I think recently even Pakistan got the exam center, but it got cancelled because of some reason. Okay.
Yeah,
So,
I'm from Pakistan. I just heard the same that it was cancelled. And
yeah,
should we
it
like
happens. Tell me.
if we are not getting the slot, we should keep applying for it with every like wherever the seats come, like Singapore, UK, Malaysia, or what, like back to back, we can keep applying.
Yes, doctor, but make sure that why you're applying, why you want to give exam. Don't rush for the exam. If you want to move to UK, try to give as early as possible. If you don't need to move to UK, if it is an added degree, wait for your home country. That's what I keep saying to all other students who are appearing. Or you can give in the countries near to you, like Nepal, your UAE, or India. So that's better rather than going for England and giving Egypt and giving exam. Okay.
Okay, thank you.
So if you have any queries, you can. I started my own coaching. This is recently which we started with 3 to 4 people. So here we are not going to charge you huge, because lot of the what do you call course providers are charging so much. So we want to make it so simple and easy, and we are not going to teach you everything that I keep saying. We're going to teach you the schematic way, the approach, how to do. So it will be like this, and every station what we are going to do will be a video, like you have to on the video. This is what a lot of course providers are differ from us, that I can say, because if you don't open the video, I don't know what you're going to do the same in the exam. If you open the video and if you communicate, like in a communication, if you, while doing a clinical station also, you can do with a doll. So this is where you have to differ from other. Okay. And if you need any information regarding to the course, how to prepare and all, you can approach me anytime. Just join this Telegram group where there is MRCPCH one stop, and a lot of material, whatever the books you wanted will be there, provided, will be available, and you can ask me without paying also. I will try to make groups so that you can join that groups and read together. There are 4 to 5 groups right now where you can join and prepare along with them. And I sincerely ask whoever wants to give exam in 3 months, try to join, so that it will be definitely useful. And we are not going to prolong it for so long. It's going to be just 1 month, not more than that. 30 minutes, we'll finish it everything, and you have another 1 month to read yourself and try to give mock in the last. So that is 60. Now I think the exam center exam dates are from September, October. So this is in July, August, September. So you have 2 months to 3 months. So make your own schedule and prepare it. And I will be available on the same thing. So the same WhatsApp number, you do message, I'll add you in the groups. Even if you don't join or join the course, I'm ready to help you guys. Okay, any doubts? This is my contact details. Try to join Telegram and WhatsApp, so that WhatsApp is better modality and easy to share the information. And I'd like to thank Aksa for because she's the one who always pushed me and wanted this to happen. I think I cleared everything. If you have anything, any feedback, you want to give information where it is not enough, so you just text me. I'll try to keep doing how to approach development. I know many of people, you have it like difficult developmental station, but I'll make sure that developmental station will be easy. That's for sure. And I'm planning to do individual. Like if you don't want to join full course, we can make it for a development 8 sessions. We can go for a history 8 sessions. We can go for a clinical. Clinical will be lengthy and time taking. So it's better you do with your exam and real cases, so that you will. I'll give a schematic approach how to do a CNS examination. So that will be definitely helpful for you. Okay. Aksa, do you want to say anything?
It's okay. Thank you very much, Dr. Siri, for this very informative lecture.
There are,
and we are nice. You're nice of so nice. We will inshallah join your group. Yes.
Yes, and we do feedback sessions. Even I will try to give what was the questions asked in my exam in particular questions in a week or something. Okay.
Okay.
Thank you and all the best. Good luck.
Thank you, doctor. Thank you very much.
Thank you.
Bye. Bye. Bye.
Bye bye.
Thank you. Thank you.